So we've got Dr. Annemarie from the Department of Health, who is going to talk us through the new draft policy on advanced practice, and we have Dr. Mary Dolan from the Nursing and Midwifery Board of Ireland, and we have a visiting professor, Professor Andrew Cashin from Australia, who's written quite extensively on advanced practice. And the purpose of today, and we also have our Dean and Head of School, Professor Feely. The purpose of today's discussion was really to try and highlight some of the areas of concern and some of the areas of, to explore, I suppose, some of the new developments that are happening in this space. I think we're very fortunate that we have a very progressive and proactive Department of Health, or in terms of the Chief Nursing and the Deputy Nursing. And I think for a small country, I think there's a lot to be said for working collaboratively to try and get the best programme possible. So hence we've opened up the webinar, and we are going to record it so that anybody who wants to kind of revisit it and pick brains is quite welcome to do so. And we're going to start with Dr. Annemarie Ryan.
Hello, good afternoon everybody. As Mary has said, that I'm currently working in the Chief Nurse's Office of the Department of Health. I'm one of the Deputy Chief Nurses who has been taking the lead on an initiative to look at graduate specialists and advanced nursing practice. And just to put this in context, I think in Ireland we're very lucky in that our Chief Nurse's Office is located within the Department of Health at a particularly high level, in that it is at Assistant Secretary level within the Department of Health, which means that it's at the senior policy decision-making table, the same as the Chief Medical Officer. So as a consequence, I suppose that the policies have that context in that they can then move into that next implementation space. And what really the policies we're trying to do is to reflect some of the current challenges within the health services in Ireland, and that these were identified and captured in two documents. One was the Better Health Improving Healthcare, a strategic briefing document that was prepared for the Department of Health when we got a new government 18 months ago, and then there was the Programme for Partnership Government. And within this, what we suggested in the CNO wrote her strategy is that that nursing, in fact, could make a contribution. What we wanted to do was look first off at the values that nurses and midwives brought to the table. And within that, last year we identified compassion, care and commitment from discussion with over 1,000 nurses within the country. And we identified the behaviours associated with that. What we wanted to try to do with these then values was to try to maximise the outcome and the outcomes of our practice, and at the same time there was a study set up about a framework for safe nursing staffing and skill mix, and that's been led by my colleague Dr. Philippa Wither-O'Ryan. Philippa's work is based on the work of Dr. Linda Aiken and the ORN forecast. And what we're doing is that we're using now an evidence base to work out how we should be staffing our wards. And it's not who shouts the loudest, but she has identified a large number she has identified the factors that should be included, including missed care opportunities, safety queues and that. And the first phase of that would be published in the next month or so. We're now going on to phase 2 of it, and we're also going on to look at how staffing should be in the EDs. The main thing we wanted to look at, though, was to stabilise the resource, and what were the things we could do at a policy level to be able to do this, and how could we deploy and appropriately maximise the scope of practice of nursing and midwifery. So within this, there are 2 policies that I'm going to give you a very quick overview on at the moment, but what we also then want to do is we want to measure this impact, and there's another paper then in preparation at the moment about looking at the KPIs and what we can do to be able to measure this. So in essence, to go back to the first paper that I mentioned before about better health improving healthcare, there were 3 massive challenges that we were really dealing with. We're looking at sort of how to get access. Can we look at primary care? Can we look at and what can we do in relation to this? What are the population health needs? How are we responding to them? And the HSE, for our international people who are on the thing, is our health service executive, and that's how we manage the health services. They have 5 integrated care programs that I'm going to talk about in a moment. And really what we want to do is see, can we change the delivery of care based on 2 principles. One, can we introduce choice for the population to access the healthcare? And then can we maximise the contribution of nursing as a response and function of the service needs and the current challenges we are looking at? So in relation to that, our government identified 2 aspects that we could develop, which we did. One is on public health nursing, and then the other was about the working practices, particularly about specialists and advanced practitioners. And what we were trying to achieve, well, the problems that we have in our health service at the moment, no more than anybody else's, are hospital avoidance. How can we avoid our patients having to come into hospital unnecessarily? What are the issues associated with patient flow and patients both getting in and coming out of the hospitals? Can we look at issues associated with early discharge, access and choice of health services? And we have a big problem currently with waiting lists, and some of this is our access and choice of health services are to do with our trolleys and what we have on things. So my colleague Susan Kent developed a paper in relation to community nursing, and we have particular problems, I suppose, within the community nursing services at the moment in Ireland. What we did was she developed a policy based on evidence, and she then supplemented it then by doing her own piece of work to see what's actually happening in practice. We have a large selection of nurses and midwives who are working across our community structures, but they all have very different governance structures, so there's no one kind of reporting relationship. So nursing is very diverse within the system. So for a patient, it's very confusing for them. They don't know how to be able to access the services or where they can get it or what would be the best thing to do. So navigating the system has become a difficulty for a lot of us, and for our patients and for our families, in fact. So one of the big impetuses from the HSE is about looking about integration. How can we best integrate community and our acute services? And at the moment, it says that they're sort of working kind of within silos and that, but what we were suggesting that the mainly ANPs and CNSs, ANPs, the advanced nurse practitioners, and CNSs, the clinical nurse specialists, these we want to be able to work, that they can work from both across the acute services and the community services, because currently they are working in either one or the other. We want to be able to see, can we provide acute services in the community and not replicate services that are currently happening in the acute services, but there are some services that are happening in the acute services that could more easily be offered in the community. We want to then to look at what our public health nursing service and see what are the pockets of integration to be able to do this. Because what she found was that there was a lot of duplication of services, there's been fragmentation of services. There was a large report that was done here in UCD last year that showed potential miscare in the community. We've got different governing structures I've mentioned before, and in relation to leadership, it's very difficult then to be a leader when everything is so disparate in its own way. We have some wonderful leaders, but it's trying to sort of bring it all together into the one space, to look at service need, to look at some of the discipline-specific competencies that we need to look at some of the regulatory standards, the values and the principles of where we want to work, because what we want to do is to work in an integrated way as opposed to working out in silos. I suppose the current services that we have in Ireland, when we're looking at our national picture, is we have very much a reactive service in the community as opposed to a proactive service. So we want to invert that, and then we want to be able to see what we can do with the clinical nurse specialists and advanced nurse practitioners, and also community nursing services themselves, and just re-look at them. Because internationally, a lot of countries have actually dealt with this. We all know about this, the population health pyramid, that most of our services are associated with the top 20%, and there's something that we can do within the nursing services. But one of our problems in Ireland, well, not problems, but our challenges, is the eligibility criteria that we're currently using. So that's one of the policy issues that Susan and I are going to have to look at. So if we were going to have some success about this, what would we look? We would have a population need by developing a nursing and midwifery workforce that has the competence to collaboratively integrate, and particularly we want to look at an eclectic model of care with the nursing and midwifery being the first point of contact. And this is, at the moment, we have services that are very good at early years, and we have some quite good services in around older years. Where we have a lacuna is actually in the working years, so the working well and having a nursing service in the community that can service those. So what we were looking then is to try to work towards more an interdisciplinary model versus a multidisciplinary model. And this particular model is kind of the model that Susan came up with, about having nursing and midwifery as the first response. And I'm going to take you to the next slide, and I'll come back to this other slide then in a moment. What we're talking about is having primary care centres. We currently have 97 of them in the country, but we could have these then that there'd be nurse-led. We have services in the community where the nurses can actually work out where is the most appropriate place for the patient to be, whether it's to go to the GP, whether it's to go to the hospital, or whether it's to stay in their care home, or we can provide some of the services then in the primary care centres around the country at the moment. Our national ambulance service is a new policy, and we will be able to utilise them for, at the moment, the only place that the National Ambulance Service can refer somebody is into one of our EDs. So they are now going to move, that they can move to a GP, but also where they will said they will bring it then to the primary care centre. We also have some community health nursing and midwifery intervention teams. At the moment, these are kind of privately organised services, and we're suggesting as we would integrate them then into our primary care team. And in particular, an example of it would be that even in a nursing home, if a patient was deteriorating, instead of having to ring an ambulance and bring them into the ED, they could actually contact the primary care centre, and nurse could go out and make an assessment on the patient. An advanced nurse practitioner could put them up on any IV antibiotics, could refer them in for an X-ray, all of those types of things that might need to be done within that service. But to come back to Susan's other model then in relation to that, we're talking then about intermediary care and anticipatory care. And this is where I'm going back to that 80% of that triangle that I showed you a second ago. In anticipatory care, we could look at some things because into our EDs, falls are the first presentation type that we get into the EDs, and the second then are respiratory conditions. So if we look at this in particularly about respiratory and chronic disease management of anticipatory care, we might be able to prevent the patient having to come in every 5 and 6 weeks if we get them sort of at 2 weeks and 4 weeks, and we make interventions at a more appropriate time. Continuing complex care in the community is something that's very disparate at the moment. You can get, it very much depends on the geographical area. We want to be able to streamline some of that, and we want to keep something that we have that's really good, that other countries want and don't have, and that is our protection, promotion and prevention activities. And there is new legislation coming in into protection of the older person, so this actually is going to create a large body of work that we're currently not addressing at the moment, while we're addressing it in a little bit disparate sort of way, but there'll be new challenges associated with the new legislation. So coming back to what she's hoping is, she's hoping for a new model of how we're actually going to do governance, and we have a paper that we would like people to go onto the Department of Health's website, onto the CNO's office, and we have something there we would like you to contribute, particularly into the governance models, because Susan has 4 different types of governance models that she would like to. So to get on to my particular one about advanced practice, I want to be able to support Susan's model then in relation to advanced practice. Currently, we've had a model for advanced, we've had a career pathway for advanced practitioners since 2001. But we have, with 65,000 nurses on the register, 36,000 of them working within our public health service at the moment, we only actually have about 200 advanced nurse practitioners that are currently in post working. And of that, we have 78 of these, or actually gone up now to 82, are working in our ED departments. And we have 53 specialties. So we've created this micro-specialisation of nursing, and so at the moment we don't have a critical mass to be able to show that we make a critical difference. We've wonderful nurses who are doing individual work, but what we want to be able to do now is to look and see, can we create a critical mass that can come back to the problems that I mentioned to you earlier in relation to this. So when we looked at some of the things about the OECD, and we know now as well that Australia are looking to get 2% of the population as an advanced practitioner, we're saying, well, we're going to try and do the same by 2021, going from a low of 0.2%. So that will give us 700 by 2021. Okay. Sorry, I have the wrong slide up for that. I didn't realise. I beg your pardon. So that's that slide that shows the different things. Okay. Many people here who are around on this webinar, I'm sure, know the benefits of advanced practitioners, but and like that, I say, our problem is that we don't have a critical mass of them working in particular specialties in that. But in relation to chest pain, we have this particular, the patient experience times were reduced from 17.5 hours down to just below 8 hours. But more importantly, 76% of the patients didn't have cardiac pain and didn't have cardiac difficulties and were able to be discharged safely to their GP. But the other 24% of patients were actually picked up by the ANP and very safely managed. The other example I have on this slide is about the advanced nurse practitioner and older person care, and this is an interprofessional team approach. And this was a particular Midlands hospital where they used this particular thing, whereas the team was led by an advanced nurse practitioner with OTs, physios, speech and language therapists, dietitian, chiropodist, all of that interprofessional team working to get the patients out within 10 days, because after 10 days, as you all know, patients then get further cognitive impairment and physical impairment if they're and these are patients that I should have said, sorry, that had either had a stroke or had a fall, so they'd had some significant sort of physical and some of them had assault of some description, you know. So once they got this very intense, led by nursing, it worked, absolutely worked. But all the literature will tell you about the enablers and the barriers. If we have strong leadership, so this is something we're looking at. We're looking at transitional planning, and I think that's something that we need to look at as well. That has been very good in New Zealand in particular. And one of the principles we want to be able to do is we want to be able to enable and facilitate nurses who come to Ireland and they can be recognised and having qualifications, because at the moment the current model doesn't facilitate that. But there are barriers, and we acknowledge them, and most of those are to do with culture and managerial issues, regulatory restrictions and financial barriers. So what we want to be able to develop is a critical mass of advanced nurse practitioners, 700 by 2021. We have a timely way in which we want to do it. We want to develop a broad-based educational curriculum. We want to have a credentialing pathway, which will be very new to us in Ireland, and we want to be able to support integrated education if we can. The model itself that we're looking at is a little bit complicated now in this particular circle, but we were delighted that this emerged from the evidence review that we commissioned from UCD. And what we're suggesting here is that our graduate nurses, they finish their education programme with a broad base of competencies. And what we want to be able to do is to create an environment where they can develop their capability. And the capability within specialist practice or whatever the area and environment that they're in, that they can then work towards being an advanced nurse practitioner if that is their choice. But we're suggesting that within the advanced nurse practitioner community, if we're only aiming for 2%, then 98% is the rest of the workforce that we're looking at. So we need to be able to develop the capability of those, and that's where the credentialing model comes in. And we have a facility within our legislation to be able to annotate these on the registration. So we have a number of pieces of work to be able to do that, but that's one of the things we have to do. But the education part of this, I think, is particularly important. We want the education to be able to meet service need, and the service need that I mentioned to you before. And we're basing it then on the 6 areas of person-centred care, professional ethics, professional leadership, consultation and collaboration, clinical scholarship and accountability, to be collected within a portfolio and through a credentialing model if at all possible. And the other big thing that we're going from is that Mary Doolan now will explain to you now in a few minutes as well, where the model that we have had in relation to timelines, and that what we're looking at here is we want to be able to support integration and service focus. And then they're the top lines of what I'm talking about here. Into the acute primary care, social care, and mental health services. So chronic disease management, one of our biggest challenges, and it's the same around the world. Older person care is another. And patient flow, and we're looking at patient flow as unscheduled care. So those are the 3 priorities we want to look at. 4 demonstrator sites that we're hoping to start this September. We're looking then at credentialed education, specialty certification. So in real terms, we're talking about a patchwork where nurses and midwives can pick up the particular qualifications. The column to the left there shows the particular registration competencies and registrations that we currently have within the Nursing and Midwifery Board of Ireland. And the thing that's going to be the big difference here is that we're moving from having to have 5 years in the last 7. We're inverting that from the regulatory point of view to make it the minimum of 2 years, because we're putting it down. That's the minimum as the education. We don't have any evidence to show that 5 years or 7 years or any other length of time is something that somebody needs. What we can say is that you have to have particular competencies achievement, and you have to have supported education within your clinical experience to become an advanced practitioner. We're not putting a deadline on particular timelines. And it's the same with the clinical nurse specialist, is we're saying that the minimum length of time is to do a postgraduate diploma at 1 year. And what we're hoping to achieve out of this is to get responsive deployment of appropriately skilled staff. We can determine where skills are required. We can then focus the education budget to meet service need. And we see this as being a retention strategy based really on the work that was done in the King's Fund. We also want to build in succession planning. We have to start building teams from our graduates through to our specialists to our advanced nurse practitioners, or even just the graduates straight to the advanced practitioners. We see that there's going to be efficiencies in relation to this, but our big focus is on access to services, hospital avoidance, integrated care and waiting list reduction through using the skills of advanced nurses. We see that nursing midwifery has the capacity to bridge the gap between access and coverage, to coordinate increasing complex care, fulfil the potential as primary caregivers to the full extent of their education and training, as was suggested by the Institute of Medicine, to enable the full economic value of nursing and midwifery contribution against the care settings, and change the reference point from which nursing and midwifery is judged. So I have one slide here that it'll be available that Mary can show to you, and this is sort of like the summary of the policy solutions that we say, well, what can be different? And it's really that we would maximise the skills for the graduate, would reduce the length of time for becoming an advanced nurse practitioner and an AMP. We move from an education based on current needs and priorities to meet our service needs. And we want to move to an enabling credentialing system that facilitates nurses and midwives and recognise these credentials through a portfolio. So in summary what I have, Mary, for you. So in real terms, we have an action plan then for the next part. We have a steering committee that is currently being developed. We have monies associated with this now for the next 2 years, where we will have to develop a paper then for the minister to be able to show that it's either working or not. So we're going to do demonstrator sites, and we're going to do then an educational pathway, and we're going to hopefully, that's going to tender then shortly. So there'll be an education pathway starting in September, and we'll also then have these demonstrator sites, and we'll have them report to the minister 2 years later.